The reason I got into these procedures is because I specialize in multiple sclerosis and I had a lot of patients who don't tolerate medications very well. They're already fatigued and dizzy and cognitively impaired. So I needed something better to treat my patients with, which led me to nerve blocks. And I do a lot of nerve blocks because I find them very effective with a paucity of adverse effects. I've seen nerve blocks work on people where nothing else works. So we have a large number of patients at my clinic in Calgary at the Alberta Neurologic Centre where we routinely do nerve blocks for people that may not have the healthcare insurance to pay for medications, and B, nothing else really works, and C, as an adjunct to whatever therapies we've got. Can everyone hear me without this thing? Oh, but we got to be special because of you. Okay, all right. So I do have a few commercial interests. I can tell you how exciting it was to get to that point in my career where I actually had a commercial potential conflict. I don't have any conflicts, but I have been paid to talk before. And I would talk for free. It's awesome. Yeah, I know I'm staring at it. I'm trying to look at everyone else while I glance at my slides, pretending like I actually know what I'm about to talk about. Yeah, of course I know this stuff. I made these slides at least like 5 hours ago. Okay, so these official objectives. This is the outline. So we'll start off with how they work, how we think they work. I scoured the literature. Honestly, people, I've been doing this for a long time, and I thought this time I'm going to sit down, I'm going to find exactly how they work and explain to everybody. I don't think anyone knows exactly how they work, but we've got a pretty good idea. When to use these nerve blocks, who might benefit from them, and considerations about the techniques themselves, where to inject, how to inject, and my personal tips for improving outcomes and minimizing adverse effects. And we'll quickly touch on the SPG blocks. So how do they work? The trigeminal cervical system is a two-way road. So basically you have afferents coming into the TCC, that trigeminal cervical system, TCC, from the trigeminal nerve anteriorly and the cervical system posteriorly. These, the greater occipital nerve, lesser occipital nerve, third occipital nerve, posterior auricular, all empty into C2, C3, and these come into the TCC from below, whereas the trigeminal afferents come in anteriorly. Okay, this is where my picture's faded out. But as you can see, the TCC complex, you've got two sets of afferents coming in, and they overlap. There's a lot of interneurons in here, and they overlap, and the message is carried up superiorly to thalamus, into the limbic system, into the hypothalamus, as well as the somatosensory cortex. And so this gives rise to convergence theory, and it's also, we're all familiar with this from the referred pain. So people with heart attacks or MIs will feel pain in the arm and in the jaw. We know they're not connected contiguously, but the nerves at one point in the pain processing center overlap. It's the same thing with the C2, C3 nerve roots and the afferents from the trigeminal system. And as these neurons come in, you've got the, in this slide here, you can see you've got the afferents coming in, and then on the secondary neurons have the targets for opioids and triptans, etc. So they all come in from multiple centers, and they're integrated and then ascend. And the higher order pain processing centers don't distinguish exactly between where the pain message is coming from. So in this way, you set up what allows this referred pain. So people who have irritation, say, of the greater occipital nerve will actually feel the pain retroorbitally. So when we talk about migraineurs feeling the pain in certain areas, the pain that they feel may not be coming from irritation of the exact area where the pain is coming from. And this allows us to target, suggest that we should be targeting the occipital nerves for treating pain that may be manifesting elsewhere. At the same time, you can actually target nerves of the trigeminal system for pain that may be arising in different areas posteriorly. So how do I explain this to my patients? So if you look at this slide, look at the bottom right, you can see the TCC. The TCC sits at the center of how migraines are generated, and this is just a slide of migraines, but of course this process applies to many types of headache. The TCC accumulates this pain, and the pain that comes into the center is not just from the trigeminal system, not just from the cervical system. It comes in from all those irritants that we know about migraines, right? Bright lights, loud noises, smells, sleep deprivation, all these things that irritate cortex. This information, it just basically funnels in a certain amount of irritation, which trips a certain threshold. And then you add that to irritation of the greater occipital nerve, lesser occipital nerve, et cetera, and it creates this pain that in turn generates migraines and allows the migraine process to propagate. And so when you establish now the migraine, the nerves become more sensitive. These more sensitive nerves get irritated. And the more the nerves are irritated, the same way that bright lights irritate the brain, the same way that loud noises irritate the brain, these nerves irritate the brain some more, and add in to this process. Then, of course, the process makes the nerves more sensitive, et cetera, and around we go. So when I'm explaining to my patients why I'm doing these nerve blocks, I'm breaking the cycle. We're just stopping that whole feed-forward process. So, efficacy in the literature. Folks, there's so many papers. There's reviews that have looked at over hundreds of publications on greater occipital nerve blocks primarily. And I started twice making a table, talking about the results, and then realized this is ridiculous. If you're going to do the procedure, if you believe a word of what I'm saying, you're going to try these nerve blocks, and you'll see for yourself that these are effective. Number needed to treat, I would say, is less than 2 to get a good outcome. In the results of, and it's hard to do a randomized controlled trial when you're injecting a local anesthetic that freezes your head. It's pretty easy to tell if you've got something that's freezing a nerve versus a saline. So the data is there, and it's very good. And so when to do a nerve block as per the literature. There's a lot of evidence that supports greater occipital nerve, in particular because it's the easiest one to do, single or unilateral, bilateral. The evidence is all very good. In the case of cluster headaches, the evidence is particularly good for occipital or greater occipital nerve block with steroid. But there's evidence for occipital neuralgia. I can't even read the slides. Oh, I'm back. I can read off my own slides now. Cervicogenic, chronic daily headache, acute chronic migraines, and then the trigeminal autonomic cephalalgias. I've got multiple patients in my practice who have other reasons for getting nerve blocks. Probably you've seen things like this as well. Skull injuries, face injuries, post-surgical poor outcomes where nerves get dinged, neuromas probably develop, nerves that have been previously cut as part of an ablation procedure to try and improve headaches, but the headaches actually get worse. So we target numerous different nerves, and you'll probably find situations where a focal nerve block will be effective for your patient who doesn't fall into one of these particular categories. When to do a nerve block, practical answer is if you can push on a nerve and there's pain when you press on that nerve, you should try freezing it. Freeze the damn thing. And it sounds like a very cavalier attitude, but when you've got a treatment where there's really not a lot of adverse effects, minimal, why not? So just give her. Anyways, finding the targets. So when you read clinical trials, reviews of clinical trials, they'll talk about measurements, 2 centimeters over and 2 centimeters up from midline, 1.5 centimeters posterior to this and that, and 1/3 of a distance between the inion and the mastoid process, and 2/3, and then you got to get a ruler. What do you wear, a ruler? No one agrees on anything, which is one of the problems with trying to do reviews, is that no one does the same thing. So what I propose and what we do in the clinic, and good to see Anne from the clinic up front, very good. But you know this stuff, you can go. Even in the literature, we know that there's a lot of variability in the greater occipital nerve. So relying on a measurement is not as the most effective. And no one can agree on the exact measurement. And then knowing that the ability to reproduce the headache at a certain spot leads to efficacy, so what I teach people is just to find the spot of maximal pain and inject there. And that in turn, it turns out, was a recommendation of a recent large review, was just find the point of maximal tenderness and inject there. So we're going to show some figures of the nerves that we target. This is the occipital region, obviously. If you can't identify this, then maybe you're at the wrong conference. You can see the posterior auricular nerves paired running up to the middle, and these aren't often targeted, but a lot of patients will actually have pain over the third occipital and the posterior auricular nerves. So it's good to keep those in mind if you're in the area anyways and you're holding a bunch of bupivacaine in your hand, have a shot. So what I would direct your attention to is the nuchal ridge, which is demonstrated in this figure. And what I suggest people do is, as you palpate, just start over the occipital notch, just below the inion, and just run your finger. And if you even did it on yourself right now, any of you who have migraines will probably find exactly the spot where the greater occipital nerve is sitting. Just apply moderate pressure, and you just, okay, can you see the back of my head back there? Just run your finger up and down over the nuchal ridge, and you'll find the point of maximal tenderness. And that's where you inject. And this kind of just stripped away shows this. So this is how deep I go. This is my finger. So at this point in this slide, I have found the point of maximal tenderness. I have moved my finger down, the same finger that palpated, I've moved it down and used that finger to support the needle when I then inject it about 5 millimeters deep over top the target. This is 1.2 cc's of bupivacaine injected over the greater occipital nerve, and this is how wide an area it covers. That's 3 centimeters. So when people talk about fanning, you've probably seen this demonstrated. This is the reason I don't fan. The likelihood of hitting a nerve, hitting an artery, or just inducing more pain to spread out to cover a larger area when you're already covering 3 centimeters with a single 1.2 cc injection. If you can't find the nerve within 3 centimeters, I can't help you. And you should step away from the patient. So if somewhere in the 3 centimeters is going to be a nerve, and that anesthetic is going to hit that nerve. The auriculotemporal nerve, if you inject Botox, you know you fan out around the auriculotemporal nerve. In this figure, I've shown you where the superficial temporal artery runs in relation to the nerve. So when I'm injecting, I tend to go a little bit more posterior, just straight up from the tragus, and perhaps a little bit posterior, just to avoid any possibility of hitting that artery. And here we demonstrate. Now, in the literature, the best evidence is for injecting the supraorbital nerve. Curiously, when we do Botox injections, the Botox is going over the supratrochlear nerve, not the supraorbital nerve. Unless you do a little bit in the corrugator tail, the tail of the corrugator, but that's not what this talk is about. I really like injections over the infraorbital. So in figure 2C in this figure is the infraorbital nerve. For anyone who describes pain behind the eye, pain over the cheek, down to the teeth, I've had a couple patients now with dental extractions causing atypical facial pain where the tooth was extracted and maybe the nerve got dinged. Injecting the infraorbital nerve can be very effective for that. And there's the territory covered by the infraorbital nerve, so you can kind of see how that nerve would actually play a role in propagating pain from dental misadventure. And these are the veins around the eye and the infraorbital nerve, which is why I inject very superficially and then just palpate the anesthetic deep, because you get a lot of bleeding. And sutures create point tenderness. I discovered this on a patient of mine who had a lot of pain over the temple. He just pointed to the spots that were really hurting him. So I palpated, marked those spots, injected the spots. Then I stood back and looked at it, and I recognized the pattern of the injections. And then I'd seen this before, and I went, and it turns out that the nerves, as the auriculotemporal nerve crosses over the suture, creates a point of tenderness. And those are the points that I had injected. This same phenomenon occurs where the supratrochlear and supraorbital nerves actually cross over the coronal suture, creates a point of tenderness. So if you're injecting, look for tenderness along the sutures. These are the risks and considerations. You can read these. The presentation, I understand, is going to be available online, so I'm not going to spend a whole lot of time going through all these things. But one of the nice tricks is during pain during injection is to inject slowly if people have a lot of pain, and use the smallest gauge needle possible, of course. In terms of bleeding, what I've discovered over the years is if you withdraw slowly, so take your finger off the plunger and withdraw slowly, you get a lot less bleeding. So the extra second or two that you take to slowly withdraw your needle is going to save you 10, 20 seconds of clotting, like wiping up blood. And I like to leave no trace when I've been jabbing people in the head. The lightheadedness is fairly common post-procedurally, so people can lie down. And of course, you sterilize the area. And the one thing to point out is be careful if there's been any neurosurgical procedures or there is compromise around the scalp, because you don't want to inject into CNS. So a few notes. Injecting more sites improves the overall effect. There's some research showing this. So if you're targeting greater, you might as well in the neighborhood at least inject lesser occipital. At a minimum, I typically inject greater and lesser occipital and the auriculotemporal. You've covered a huge percentage of the scalp. And after the nerve blocks, if people report the rebound pain, which is not uncommon, we see about 5 to 10% of people have, especially if you inject large amounts, or on the first nerve block inject too many sites or too much fluid, they may have a headache. So we use an ice cap afterwards, and you can see how happy these people are wearing their ice helmets. Except for the blue. No telling what the blue dummy's thinking there. These are the doses that you want to be underneath. I can't quite make out the numbers, but you can inject a lot of bupivacaine before you would get yourself into trouble with that one. Aspirate or not, this is a point of controversy. I don't aspirate. There's reasons for that. There's no evidence to support that aspiration actually helps. You're injecting very small amounts. Even if you went straight into the artery, you're not going to cause any side effects. You're doing infusions of anesthetic in hospitals for pain all the time. So a little bit won't cause a problem. Moreover, I've seen too often where people aspirate, and as you're aspirating, you shake the needle a little bit. So say you weren't actually in an artery, but you were beside an artery, then you're trying to withdraw to make sure you're not in an artery, but as you do that, you start shaking the needle a little bit. Then you're talking about a shear injury. So I don't aspirate. Don't call the college on me. Okay. Yeah. When to use a steroid, the only indication for a steroid is in cluster headaches, but there are occasions where a person will have irritation, and if nothing else works, sometimes there have been times when just steroid injection alone can do the job, but you don't want to do that anywhere but over the greater and lesser occipitals. Timing, the benefit typically occurs in about 10 to 15 minutes, so we use this a lot for people we're trying to keep out of emergency. Stop by the clinic, call the clinic, come in, get an injection, 10 minutes later the headache could be gone. Typical injection duration is 4 to 6 weeks. In our clinic, we'll inject anyone who, if it gets you 2 weeks, nothing else works. If you get 2 weeks headache-free, we'll see you again in 2 weeks. There's some evidence and expert opinion. This isn't my expert opinion, although with Dr. Becker's backing, I guess at least saw some prestige and authority on the subject now. This comes from a lot of leaders in the field that nerve blocks with lidocaine might be the most effective treatment for migraines in pregnancy. You want to use lidocaine, not bupivacaine. Lidocaine is a larger molecule, doesn't cross the placenta as readily or at all. GPs at the refugee clinic, I taught this to. There's two things. People from a lot of other countries actually put more stock in procedures than they do in medication. So these treatments may be particularly of benefit to people outside of Western medicine. And for people who don't have the money or healthcare insurance, a free nerve block is fantastic. They're safe in pregnancy. And what if this is a question that I fielded from other neurologists in the past, and I can't believe I still have to. What if it's placebo? I don't care. I mean, you get to the point. If it works, if they're pain-free, there's a certain point we get to, and if you all treat people in pain, you know what I'm talking about, where if it's placebo, that's fine as long as the pain is better. And then there's the SPG block. How am I for time here anyways?
5 more minutes.
Oh, perfect. I can stop racing and slow down and enjoy a talk about sphenopalatine ganglion blocks. So there's a target. It sits at the back of the nasal cavity. It's integrated in the V2 distribution. The initial indication for sphenopalatine ganglion block was trigeminal neuralgia in the V2 distribution. particularly effective for the trigeminal autonomic cephalogists. I would say that the sphenopalatine ganglion blocks that I do are better at treating the attacks than nerve blocks are. Also effective in migraines, pediatric migraines, and sinus headaches. So we're going to talk a little bit about sinus headaches, and also for the post-dural puncture headache. Now, my ideal patient for this, when they talk about sinus headaches, is someone who has seen ENT, had a CT of the sinuses, and the ENT says, I see nothing. Then they get put back on a list to see another ENT 3 years later. And the CT sinuses shows nothing, but there's something there because they've always got this sinus pain. It's probably not. There was a study done out of the Mayo Clinic where they recruited 100 people, self-referred, and what type of headaches do you have? So if you have a sinus headache, we'd like to talk to you. They come in, they see a neurologist, and they're diagnosed. 75% of the people that came in with a self-diagnosed sinus headache actually had migraines. A very small percentage, 3%, actually had rhinosinusitis, which is in line with what the ENT studies have shown on the very same topic. So these people who have self-diagnosed sinus headaches stand to benefit greatly from SPG blocks because that you're actually targeting the SPG right in the middle of the pain, and it works very well. And finally, one last comment. I know it's outside the topic here, but I've been using this increasingly much. And for those of you injecting Botox, if you happen to have patients with comorbid depression, there's really good evidence. I'm not going to get into that, but if you look this up, really good evidence for Botox in treating depression. 29 units in women, 40 units in men in the glabellar region. So 20 units odoproceris in addition to the 5 that you're already putting in the corrugators is a great treatment for depression. I've used it in many patients myself, and the data is there in the literature. It's very good. Finally, gate control theory of pain. When I'm doing Botox, if you have patients who just can't tolerate the Botox injections, they wince at every single injection. This is the gate control theory of pain. Who here has heard of the gate control theory of pain? Oh, I need not get into it then. So they don't just, I'm done. No, I'm kidding. This is I spent the time and put the figures in. We'll talk about it. Basically what it is, you've got 2 sets of neurons. You've got the pressure sensing neurons, and then you have the unmyelinated or lightly myelinated C and A delta fibers. If you activate the large myelinated fibers, you override the pain coming in from the C and the A delta fibers. So what I'll do when I'm injecting Botox is I apply a large amount of pressure. I actually have the patient press back or press sideways against my finger and inject, and a large percentage of people, I've only started doing this in the last couple of months, I really had to mention it to everybody, a large percentage of people can't tell when you're actually injecting the Botox. So this works. So if you have patients, and if you do inject Botox, if you're thinking about them right now, a lot of pressure when you're injecting, they don't wince, it actually works really well. Yeah, and this just basically figures that tell you just what I just told you, but basically when you activate the A beta fibers, you override the C fibers. So that's it for me.